Good afternoon, everyone. Here I want to explain the innovations in laryngology during COVID 19 which we implemented in our setup. We all know the guidelines have come up by saying that do the social distancing, screening of the patient while entering into the hospital, and adequate distance between two patients. In the OPD, what we do that we wear the dedicated scrubs which we generally change before leaving the premises, so that we should not take the contamination to our home. This talk is specially for laryngology purpose, so we will just focus on the laryngeal procedures. So I would like to say that ideal examination we have omitted. We are not doing ideal examination, or in fact the Hopkins without the camera attached at all. Majorly we follow this flexible scopy if at all it is required. You all must be using this camera sleeve for our functional endoscopic sinus surgery cases. Those camera sleeves we have cut approximately 2 centimeters longer than the tip of the flexible scope, and we tie that on the top, and we provide the 3-ply surgical mask to the patient and create one hole which will be approximated to the one of the larger nostrils, and then we insert this flexible scope through that hole with the sleeve attached. After completing the procedure, we gently take out it and quickly close it to prevent the aerosol and droplet contamination in the surrounding, and then hand over to the sister. Next thing comes to the OR procedure. No matter it is a COVID positive or COVID negative child, we do use the respirator, full PPE kit, the visors, everything, because the post-infection, the lower respiratory tract secretions can be positive for 69 days. Means if the patient has got the COVID some 2 months back, so definitely still he can spread that infection if the 69 days are not crossed. So we take all precautions for the same. In our earlier days, when the COVID just started, to prevent the aerosol generation, we started using this plastic sheet. It's just a plain plastic drape or the plastic apron over the patient, and surgeon can see through and through on that very clearly. And rather than going with the eyepiece, we directly go with the camera attached. But then later on, we developed this device, this plastic see-through transparent box, which has to support handle for the transport, and 2 surgeon's arm holes in the red arrow you can see to insert the surgeon's hands inside, and the space on the back side here to insert the instruments and for the assistance by the sister. And the pediatric airway surgeries in COVID era, we have explained all this draping techniques and methods and some recommendations for the procedure, which has been accepted and published in Indian Journal of Otolaryngology and Head and Neck Surgery. Then a few words on tracheostomy. I know tracheostomy is not purely laryngology concern, but yes, it is the part of the airway, and this is again important to know and to understand. So no innovation actually, but there are anyways various guidelines and recommendations have come, which is difficult to remember and difficult to follow. So we have created innovatively one acronym, COVID TIDE approach, specifically for COVID tracheostomies, where C is for covering guideline, O is for operation theatre planning, P for ventilation precaution, that when to stop the ventilation and when to resume, the incision precaution related to the COVID, and doffing protocols, the tube change and the inline suction and the decannulation, and ultimately the expert airway team. We should do this procedure quickly and without any mistakes. And again, the COVID TIDE approach has been published in Indian Journal recently. So if you are interested, you can read this in detail. Thank you so much.